Good morning. This presentation is going to be on the quality control process, which is chapter 19 in your text. Just what is the quality control process? Really, it's a specific type of controlling done by management or leaders that evaluates, monitors, and regulates specific kinds of services that are rendered to consumers. That's the whole idea, is to assess kind of services we give to consumers. Components of the quality control process is that it has to be supported by top administration, not only with human people, with people, but also with finances. So what are the steps? What are the process? The process is that first a criterion or a standard is identified, then the data is collected, and then either education is provided or corrective action is done if the policies and procedures are not being followed. So this is a predetermined level of excellence is where the criterion and the standard is. And where do those come from? Come from the ANA standards of practice for care and performance, comes from organizational standards, and it comes from clinical practice guidelines. Typical types of things that there's a criterion or a standard for and that they're measured are like pain, how often pain is assessed, the core measures, hand washing, CAUTI and CLABSI, things that you are already seeing on the unit that help you understand what kind of services are offered to our clients and what the outcomes are going to be by whether we follow procedure or not. So first, the criterion or the standards determined. So that's the control. Employees have to understand what they are. That's why we always tell you, go find the policy, go find the procedure. You can't expect people to follow or to do the policy or procedure if they don't know. That's why there has to be monthly updates if the policies and procedures are changed. That's why actually all nurses need to be a part of the policy and procedures, writing and changing them so that they know what they're about. In this day and age, we also have what's called benchmarking. This is where there are institutions that are performing at a very high level. They meet their criterions or standards 95% of the time. And so organizations benchmark against them because they want to see, and then they see how do they meet them? What do they have in place to be able to meet that criterion like it is? They're the role model, and they're the yardstick. So then the data collection. How's the data collected? First, you have to identify what information is relevant. If I'm measuring how care is done after surgery, I might want to measure, first of all, what does the policy say about how often I'm going to take vitals, and then I'm going to gather data that shows how often the vitals were taken. So these are called audits, and there's specific ways or specific data that is collected. So we determine how we want to collect the information. We then collect and analyze it. But then you can either do a retrospective audit where you collect data of care that's already been given. You can do an outcomes audit where you can look at the outcome. All of these patients had a Foley. How many of them ended up with an infection? So you can do an outcome type audit. You can do a process audit that looks at the processes of how we do our work and how we provide care to our patients. The problem is sometimes the danger can be that as we look at our standards, we look at our outcomes, sometimes there might be a tendency to lower our standards. If we never can hit it, then should we lower our standards? But that's one of the things that can happen. So step 3 is data collection. Then step 4 starts at collect and analyze the information. Then compare this collected information with your established criteria. If the vitals are supposed to be taken at 15 minutes, 30 minutes, an hour, Q4, Q8, how often are we doing that? If this is the protocol of how long the Foley is to stay in, what's supposed to be assessed about the Foley, are those things happening? So you compare that collected information with your established criteria, either your protocol or your policy. And then you make a judgment about the quality. Are we meeting the standard that we set? The next then is, what do we need to do? We need to provide the information that we found out, and we need to decide, does corrective action need to happen, or does education need to happen? So did a policy change and staff weren't aware of it? Did new evidence-based practice information come out and that wasn't communicated? Or do we have a performance problem where this is what the policy says, this is what should be done, but for some reason people aren't following it? So then that becomes a corrective action. Then after a certain length of time, you go back and you collect the data again and you reevaluate to see if your education or your corrective action has helped. And then you continue to do that and usually do it on a plan. There's usually a plan about what's going to be evaluated, how often, who's going to evaluate it, and then what's going to happen. Now, I want you to be sure and read the information in your text and in your ATI book about QI. It's a hot topic, and there are lots of questions on it when we take the ATI exam. There's only a couple of things left that we need to discuss. Quality measurement, it's an organizational mandate. What are the external? There are external impacts on it, like Medicare and Medicaid. When we had skyrocketing costs, they started to put measures or standards to help us have better outcomes and better care. First of all, remember what the DRGs are, the cost of diagnostic and related groups. So they started to put prices, they started to put costs of what they would pay for different kinds of procedures. And then the prospective payment system is what the whole world is going to, the whole country is going to, where you get, instead of fee for service, every time you go to the doctor, get a test, it gets paid for. Instead of, you get this lump sum of money for all of these patients. And then you get it all at once. And then every time these patients use care, you take out of this pool of money. This is all you get. So you need to manage your care and manage your patients very well, because that's all the money you're going to get. The CMS, of course, is Medicare, and they set a lot of standards that insurance companies follow as far as what they're going to pay for. Like we know all the things about readmit. If patients are readmitted for certain things, COPD and pneumonia, they won't pay for them if it's in with 30 days. And now this report card and transparency, infection rates, readmission rates are all being reported on hospital websites and institutions' websites, so people can see how well they are doing with their infection rates and their fall rates and different things like that. So much more transparency to help bring quality to the front and for quality to be for everyone to know the quality of your institution. Now we also know there's huge decreased length in stay. Patients are going home much sooner. They're going home with much higher acuity to being cared for in the home or by home health. A lot of people think it's decreasing the quality of the care and the quality of the outcomes, but that still is being measured and discussed. Medical errors, just a little bit about it. We all know that there's a lot of medical errors. There's an increase in reporting. I want you to look up the leapfrog and the reformation, and we're going to discuss in class a little bit more about progress. But how are we doing when it comes to medical errors? How are we progressing? And what differences are we making? And how is the complexity of our healthcare environment impacting our progress and our reporting? If you have questions, please email me. I will be sending out more information.